presentation.
All right, so okay, we're up and going here. We'll start getting all the attendees to come in here.
Good. So hopefully nobody gets too dizzy with this first slide.
Yeah, no kidding.
Look away.
It's looking great already, Giacomo. Good job.
14, wow. People are pouring in already.
All right, folks, welcome so far. Thanks for joining us tonight. We've got a huge crowd of interested people that want to learn a little bit about vertigo and dizziness. It's a very common topic that comes up in our physio offices for sure. Giacomo, I'm sure you hear a lot of patients reporting symptoms. So
yeah, surprisingly, we're starting to see more of this in the physio office than some of the local ENTs are referring to physio now for some of the more maybe some of the less complex stuff. But it's not your first go-to is physio, and we'll talk a little bit about maybe why it should be at least. Yeah, I see some familiar names coming on board there.
Yeah.
Hello to everybody. I won't say names for privacy purposes, but I'm seeing some long-term patients of ours, Mike. So that's good to see everyone.
So for anyone who's new, we've been hosting a number of webinars here with our two clinics, Aurora Sports Medicine Professionals and Nobleton Physiotherapy. So welcome to everyone. If you're new to this with our webinars, one of the quick things we like to do is we like to use the chat button. So there is a chat on your bottom toolbar. We'll show that later in the presentation. And when you type a message in, you can hit the drop-down link to say all panelists and attendees, or just all panelists. If you want your comment to be to everyone, all panelists and attendees will do just fine. So maybe just to practice on the chat, that we always like to get a little bit of banter going in lieu of Thanksgiving that has just wrapped up this weekend. It was a beautiful weekend. What does everyone prefer? Now pick one, apple pie or pumpkin pie. So type in the chat if you want, apple or pumpkin. Oh, Danielle, there you go, apple.
Right off the bat.
I'm a pumpkin pie person, and I did not get pumpkin pie this weekend.
Ooh, wow.
It crushed me. I'm the only one in my household that likes pumpkin, and maybe
because you didn't make it. You know what?
Well,
you should make your pumpkin pie, Mike. You know.
I know. I know. You know what? My wife made the apple pie because her and the kids love apple pie, and I just I said, you know what? I'll take whatever, but yeah, I'm a pumpkin.
Yeah, I see on the panelist or on the list of attendees a Lake Dalrymple attendee. So we made some apple pie with some apples from just a long dirt road, a wild apple tree from in the Lake Dalrymple region area there. So it was amazing.
Nice.
Really amazing. So yeah, apple pie definitely, but pumpkin pie once a year. So you got to go with the pumpkin pie. It's a no-brainer.
Okay, and then the follow-up, I guess we've got the dessert taken care of. What about the meat, the protein? Are we turkey or ham or prime rib? I don't know. What's everyone? Okay, turkey. We got a turkey. I'm a turkey guy. Like, come on. Who doesn't want turkey on Thanksgiving? Barbecue fillet. I love it. And prime rib. Woo. Yeah, lamb. Turkey. Yes. Oh. I don't know about you guys, but I slept well Sunday night after that turkey dinner.
Yeah, growing up, we never had turkey on Thanksgiving, right? So it was one of those things where it was like pasta and lamb, which was amazing. But now it's definitely the turkey is the way to go. You know, prosciutto, ham and Italian is prosciutto, so that's what that was part of our meal as well. So we definitely had ham.
All right, we're gonna keep waiting for people to jump in here. We'll get started in a couple minutes here. Hey, Giacomo.
Yeah. Yeah, well,
We had a lot of registrants sign up, so I'm sure they're all just logging on now, realizing it's 7:30 and they want to hop on and listen in. And I hope you know, no one's getting dizzy looking at your graphic.
Yeah, I know that was purposeful. Hey, we want to introduce, by the way, we want to introduce Erin Albom. She's part of the panelists today. She's helping moderate. So just want to give a little thank you to Erin. She's one of our physiotherapists at Aurora Sports Medicine Professionals. So a little shout out to Erin. Thank you very much.
Thank you for having me.
Yeah.
Thanks, Erin.
Yeah, she's been helping us out on practically every single one of these, haven't you, Erin? You've been moderating and helping us keep on time, keep those questions coming, and so thank you very much. It helps us out when we're doing these presentations. And she has done one herself, right? Her and Steph.
Yep.
The last one.
Yeah, exactly.
Yeah. So for all the folks that are listening, if you have a question along the way, feel free to put it into the chat or into the Q&A. And both myself and Erin, we're going to keep an eye on it and make sure that when the time is right, we can ask Giacomo these questions just for the purposes of the flow of the presentation to carry on. Okay. One more minute, Giacomo, and we'll
let's give
we'll
it another minute.
Yep.
We got a bunch of people in, and they can always you know, tie on a little later. I know everybody's time is precious here, so we'll try to keep things moving along. And there's a lot to cover today, so yeah, feel free to be asking questions. But it's a meaty topic. A lot of you I see in the attendee list there, patients I've treated with this before, and it's a complicated topic. So we're going to try to get through as much as we can. So yeah, we'll get started very shortly and follow along. All right.
Yeah, absolutely.
Yeah.
Okay. I think we should get going, Jack. We got a good number joining us right now, and I think a bunch more are going to be hopping on any minute now here. So
Yeah,
why don't you get started?
Okay. So once again, thanks everybody for joining me tonight. I said before, it's a pretty meaty topic, but one that a lot of us share, and just the term dizzy. Erin mentioned this graphic is can incite some dizziness in people. So we probably all had some episode of dizziness, and I'm going to get through some of the objectives tonight that we'll try to get through. So my name is Giacomo Fabrizio. I'm one of the co-clinical directors at Nobleton Physio and Aurora Sports Medicine Professionals. Both Mike and I share that directorship role at both those clinics. And so we've been doing this now for the better part of 17 years now in the physiotherapy profession. So we are kind of old guys at it, right? So we're getting some experience. A little bit about myself. Yeah, so 17 years in the profession. I've worked mainly in private practice, but have a special interest in head injuries and balance disorders. I worked at Toronto Rehab for a little while in their outpatient head injury program, and where I developed a bit of an interest in the balance disorders. Surprisingly very common in the population. Most of us have had some form of balance dysfunction, and hopefully tonight we can educate ourselves more about balance dysfunctions, and maybe just get a good conversation going about what's happening out there in the world of dizziness. Okay, so as Mike had mentioned, there is a chat button. I think everybody's practiced that. We got some chats going on here and people answering the questions. So it's just down here if you're afraid to ask, down at the bottom of your screen, and you just type it in. You can either send it to the panelists or to which are myself, Mike, and Erin, and we'll field those questions if you don't want to ask the question to the entirety of the participants. Or you can ask to the participants. And I always remember what they're saying, if you have that question, put your hand up, because somebody else in the classroom probably has the same question that they want to ask. So feel free to ask any question, either to the panelists or to the entire populace. Mike, anything to add there?
Nope, everything looks good.
Okay, so let's just carry on. Okay, so just want to talk about the presentation objectives, and the main thing I want to try to identify is the dizziness versus vertigo, and a lot of us, interchange those terms, and it's fine, but they are distinct in so much as how clinicians will identify them, and then to more or less get your treatment specified. So we're going to talk about the most common reasons for dizziness, and there's a lot of them. I think I read somewhere there's 80 reasons why we may have dizziness. After having a couple glasses of wine could constitute dizziness versus having vertigo. Those are two very different things, but we're going to talk about some of the most common ones that are shared in the population. Then we're going to talk about some at-home tips to manage your dizziness, and provide you with some exercises you should be doing now, even if you're not dizzy, to help with training the balance system. And we'll talk a little bit about the anatomy. It's really important to understand how we as humans, it's a very complicated thing to be standing upright and actually standing still. There's various pathways and pathologies that can come into the equation that can actually alter that. So as simple as it sounds, anybody who's had dizziness or any type of pathophysiology that would constitute a vertigo or dizziness can understand how complicated it is to actually just stand on your feet. Okay. So it's again dizziness. These are U.S. stats. So so my apologies. This was a nice poster that we can just kind of go through. More than 1 in 3 of us have some episode of dizziness and vestibular dysfunction, and so one of the things that helps us stay balanced is the inner ear. We'll go through that anatomy in a little more detail in a few slides after this. We have the eyes. If anybody, just don't do this now, but maybe later on, just stand on one foot with your eyes open, and then stand on one foot with your eyes closed, and you tell me which one is harder, or tell yourself later on. You can message me later. But and then your sense of touch, your proprioception. The way I like to describe this is, you can reach into a bag of 100 items with your eyes closed and identify most of those items just based on touch. I know that this is a pen based on feeling it, and I've touched a pen thousands of times, and that's how our body understands where we are in space and time and what exactly is it we're touching. So that helps to keep us balanced. So some of the symptoms, and this is a key word, is it's symptoms. It's not necessarily a diagnosis. Is when we have balance problems, we may have vertigo, which is a sensation of movement, and we'll talk about that in a little bit of more detail. Sense of imbalance. If you've ever stepped off a boat for a short period of time, or if you've ever been on a cruise. I've never been on one, but there's something called disembarkment syndrome that you can get, which is a sense of imbalance, or just plain dizziness. Or you may have had, you go sit up really quickly and you get a sense of dizziness that can happen. So a lot of things can happen. You can get some hearing changes, you can get some visual problems, and then problems concentrating. That can really alter the way we think or analyze and go through our problems. Treatment. There's a slew of treatments, and we'll talk mainly about the physio because that's what we do, and that's how we help people with treatment. Medication, lifestyle changes, diet, surgery, counseling. Those are all adjuncts. I always say it's like spokes on a wheel. Physio is not going to cure you, but it's certainly going to help you out because we are creatures that move, and as physical therapists, that's our specialty. So we try to incorporate movement and exercise into some of the treatments we do. So that I find that's really important because you can take a medication that's going to help you with your nausea, but it doesn't necessarily help you stand on your 2 feet and function. So we'll get into a little bit more detail, but I really like this slide because it really helps to break down what we are going to talk about tonight. Okay. So 4 types of dizziness. I apologize, this slide is a little bit, it's not your dizziness acting up, it's just the slide is a little bit out of focus. So vertigo. Vertigo is a strong sense of motion or spinning. And it's very different than somebody who says, well, I just get dizzy. And anybody who's had vertiginous symptoms can really appreciate that you can be sitting, and as soon as you turn your head to one side, it feels like the room is moving around you. Not necessarily that you're lightheaded. And that's below that, that's that feeling of wooziness or disconnectedness from the environment where you might gotten up really quickly, and there's this almost like a blacking out, if you will. Presyncope is a fancy word for just about to pass out or faint. So that is a sense that you're going to lose consciousness, and some I'm sure some of you have had that. And then a sense of disequilibrium, and that's where we're talking about earlier, where you step off a boat and you step on dry land, and you get that sense of disequilibrium, and that can last with people for days. We're not going to talk about that in detail, but individuals who have been at a cottage and have been on the boat for a little while and haven't done that in years, and sometimes complain about vertigo or dizziness. And when we probe a little bit into their history, it turns out that they're at the cottage on the weekend and haven't been on a boat for a little while, and that can give you a sense of disequilibrium. All right. Okay, our favorite, anatomy 101. Here we go. It's really important to understand where this part of balance occurs, and this is the part that as physiotherapists we can work on those other things. But for tonight's purposes, we're going to talk about the anatomy of the inner ear. So just looking at the ear here, we have the outer ear, and that's how we get we take sound in across the auditory canal into across the tympanic membrane, and then we have the malleus, incus, and stapes, otherwise known as the hammer, anvil, and stirrup. So that is what makes the sound travel all the way over to the cochlea. And our semicircular canals interpret our balance. And the way I like to describe the semicircular canals, they are, if you look at the graphic a little bit lower, you have the posterior, the superior, and the horizontal. All that, we don't have to know any of that. It's if you were to take your phone and you orient it and you flip it upside down, it's like a gyroscope. It always wants to orient itself to the upright. And what our semicircular canals do very well is we can go from laying on our backs to standing up to rotating to looking over and twisting our head, and we always know where we are based on the horizontal. And so that's what, whoever created us did a great job and said, hey, let's put a gyroscope, this little tiny gyroscope in the ear that is filled with fluid and these little hair cells that look like the Canadian plains in Saskatchewan on a windy day. And if everything's blowing in one direction, that's great. But we'll talk about when things don't blow in the right direction, what can happen. So the term angular head velocity, it's a fancy term for just understanding that the head is moving at a certain speed in a certain direction, and the body knows and the brain knows where everything is going. And we can do that with our eyes closed and be quite good at it and fine with it. But sometimes there's other dysfunctions that can really mess up the eyes with, and we'll talk about this a little bit later. Okay. I'm just going to throw it out there. Any questions so far? If everybody's doing well, we're
yeah. No, so far so good, Giacomo.
Okay, thank you.
Yeah.
Okay, sorry, more anatomy, but it's really important. So here we took away everything, and we've just left with this fancy nerve up here, cranial nerve number 8, the vestibulocochlear nerve. Fancy term, but there's two branches of it. There's the cochlear branch, which goes into the cochlea. And anatomy is not that hard. You just kind of know what the structures are, and there's things named after it. So, and then you got the vestibular branch, which takes the information from the semicircular canals back to the brain to interpret where we are, that angular head velocity, to know where we are sitting upright or laying down, and our body knows where we are in space and time. We don't have to tell it. So this will come into play a little bit later. We'll discuss why that can go amiss sometimes. Okay, so here's kind of the crux of the presentation here is dizziness. It's really hard to describe. I'll often be discussing dizziness with a patient, and we see it in other conditions. Somebody may have had a concussion and they feel woozy, and they describe it as dizziness, and that's fine. We try to differentiate that between vertiginous or vertiginous symptoms and other things, lightheadedness, blood pressure issues, and so I like to think of it as not all dizziness is vertigo. Again, vertigo is something specific. Remember, it's the room effectively moving around you, not feeling lightheadedness or as if you're going to pass out. But all vertigo makes you dizzy. I mean, you kind of have that sense of imbalance. But the genesis of it all may vary. And so we're going to talk about that in the next couple of slides. We're really just trying to build up to this here, wanting to make sure that you understand that dizziness is not a catch-all. It is a catch-all, but we can then delineate where that dizziness is coming from based on certain things we can do in the office, and then certain things that we can't do in the office where we need more diagnostic imaging. Okay, so one of my favorite Alfred Hitchcock movies. I don't know about anybody else. Anybody else have any other favorites here? Alfred Hitchcock movies, just type into the chat. This was one of mine. Birds was another one of mine. So Mike, I don't know if you had any, did you want to do a poll here?
I'm not an Alfred Hitchcock kind of guy. So
okay. Do we have one? We have somebody here.
Rear Window is coming in.
Okay, good. Birds. I like the birds. Yes, Trish. Yeah.
Do you want me to run your poll here, Giacomo?
Yeah, let's run the poll. We'll take a little bit of a break. Oh, Psycho, love that movie. So good. Yeah.
Okay, I'm gonna launch this poll. So we have a little poll here, everyone, that just a quick couple questions. So I'm gonna just send that out here. Everyone should be seeing it popping in now.
Yeah.
So feel free to start putting in your answers there. We'll see here, Giacomo.
Yeah, we're slowly 20 of 83 responded. It's good.
I'll share this. Can you see some of the results coming in, Giacomo?
Yeah, they're firing away here.
Yeah, good.
All kinds of stuff going
on. Lots of people experiencing an episode of Vertigo, so it's going to be very interesting to sort of
interpret it. Yeah. So if it is truly vertigo, it's a bit of a loaded question here, folks. You know, Mike and I were talking about this, and yeah, vertigo is a pretty specific diagnosis. But
look at the. I'm going to end it here. It's interesting. Look at the number 2, the question 2.
Yeah.
What treatment? The highest rated treatment was nothing.
Nothing. I know. How crazy is that? Like. We'll talk about this later. I know I keep saying that, but as we're getting along in the presentation, that's are you sharing this present? Are you sharing?
Yeah, I'm sharing it right now. So there you go.
It always drives me a little bonkers on, you know, nothing. The most common. We'll get. Hold on. Let's move along here, guys.
Okay. All right.
Yeah. Let's move along, and we'll talk about this because some of the things that. Okay. So here's another slide that might make you a little bit queasy. So let's go on to vertigo and the actual definition. So it's a sensation of motion when there is none. And so that's that sensation where the room is spinning, the movement is felt inside your head, and you'll see folks with a vertiginous episode grab onto everything for dear life because they're falling. They may be lying on the ground, but no, they have a sense that they are falling. They're going to hit the ground, even though they're on a bed or a plinth in the physio clinic. And so that is a really specific type of symptom as opposed to dizziness. And so back to that slide, and I won't doubt what people, if they've had vertigo, that they know exactly what that is. And that vertigo can come from a different diagnoses, but that is a very specific thing. And to say nothing for the treatment is a little surprising. So we're going to talk about the most common reason why people present in their doctor's office or at the ER for dizziness. Now, there's a number of different reasons. There's people can be having a stroke or having, you know, an issue with medication, but this is the most common: benign paroxysmal positional vertigo, or BPPV. So, you know, just looking at the definition here, it's paroxysmal means it's kind of off and on. It's positional. The key here is that it's position, and there's where the symptom is, the vertigo. So, looking at the sort of pathophysiology of it all is that we have these small granules called otoconia. For all intents and purposes, they're little calcium crystals. And early in the presentation, I described that just imagine that wheat field, that Molson Canadian commercial where the wheat field is being, you know, blown from the west, and all those wheat stalks are moving in one direction. Imagine if there was something stuck in the middle there that was blocking some of those stalks from actually stimulating the nerves that they're supposed to stimulate. So 99% of the hair cells are moving in the one direction, and there's one or two that are sitting up and saying, well, no, we're sitting right here, and it's sending mixed signals to the brain. And the brain is going to be trying to figure out where that signal is coming from or who's correct. It's really that simple, where these autoconia, and I'll show you a graphic in a second, these little calcium crystals get caught in areas where they shouldn't be, and it can give you the sense of being in a direction where you don't think you are, or your brain thinks you should be. And so it is the most common form of dizziness. It can be bilateral or unilateral, meaning it can happen in one ear or both ears. And so this is the most common reason why people end up in the doctor's office or in the ER. And there's a really simple maneuver that we can do. And a little quick story for you as we go along here. But so let's get to a graphic, and this is really important to understand. So remembering back when I showed you that graphic about the cochlea, that's the hearing center of the brain, and then the semicircular canals are these little U-shaped vesicles here that are filled with fluid, and those wheat stalks that are going back and forth. So as we move, that angular head momentum is moving around, and those wheat stalks are moving and telling us where we're going. Now, these little fancy termed autoconia should be sitting over here, but sometimes the displaced autoconia sit in one of these semicircular canals. And so the idea with the position is that depending on the position that you're moving in, those semicircular canals will try to elicit a signal back to the brain to say we're moving forward in the horizontal plane, or we've moved to the left or turned to the right. Now, any of you who have had BPPV would tell you right off the bat, I can't lift my head to the left ever so slightly, and I start to get vertigo. You know, I had somebody in my office a couple of weeks ago who, she was just laid down. As soon as she laid down, moved her head to the left, it started. Anything else was fine, but it had to be in that position. And that's one of the things that is the hallmark of BPPV is the positional portion of it. Okay, so let's go back here for a sec. We're gonna talk a little bit about how we treat this. Sorry, let's moving along. I just want, this is the slide I wanted to show you that it's this part of the nerve, the vestibulocochlear nerve, or the vestibular branch rather, that is sending the misinformed signal to the brain. Okay, so when we get a patient in the office, one of the tests we do is called a Dix-Hallpike maneuver, and that tells us we can do that in the office without any machinery, and we look in people's eyes, we gaze deeply into their eyes, and lo and behold, if they're positive, their eyes flutter back and forth, something called nystagmus, and that's your eyes trying to figure out where you are based on what the signal that your brain is giving you. And so that is one of the diagnoses. There's more to it than that. I don't want to boil it down to something that simple. There's certain directions that would tell us whether it's something benign or if it's something else a little more sinister. But that's something where you'd maybe see your ENT or your nose and throat doctor. And but for purposes of coming into the physio clinic, we do a Dix-Hallpike test, and we can convert that right into something called the EPLEY maneuver, which is one of the things that, in physio, it's kind of like, we treat people with tendinopathies and we treat people with, sprains and strains, and it takes weeks to get better. But with BPPV, if you're experiencing an episode, we can get you better in mere minutes. It is unfortunately one of the things that will make you feel absolutely worse before you get better. And so you're going to go through that sensation of dizziness and nausea, and then lo and behold, a couple hours later, you're feeling a lot better, and the positions that you can move in are far greater. So that's one of the things. And generally, we don't go to our physio for that, or at least in past we haven't, but a lot of physios are being trained in this, and taking the burden off of the ER by doing these types of maneuvers. Now, I would suggest you always go to the ER if you're feeling episodes of dizziness. Do not make a self-diagnosis of, I think I got vertigo. I would go to the ER to make sure that it's nothing like a stroke or anything else that could be leading to dizziness or vertigo, because that would be pretty catastrophic to try to make that self-diagnosis. But once you've been diagnosed with it, Mike and I did a presentation a few months ago, and it was to about, I don't know, Mike, how many were there? There's a dozen or so, 15 family docs they were residents. And
yeah, about 20. So.
Yeah, there's about 20 of them. And you know, it was one of those things where I think sometimes, you know, you go to the ER, and I've heard this a number of times, and it's not a slant on our system. It's just that it's, you know, these things can resolve on their own, and generally those autoconia are dissolved and crushed up into, you know, a little powder, and off you go in a couple of weeks. But sometimes you go to the ER and they say, okay, go to the YouTube channel and figure out how to do this EPLEY maneuver. And it drives me nuts that maneuver is not done quickly in the ER, and people are sent home with the ability to do that. But Mike and I spoke to a bunch of docs, residents, and one of the things they were asking us at the end was how to do this EPLEY maneuver. And I, by no means am I an expert at it, but doing it enough, even as a physiotherapist, we've become, you know, pretty good at it. And it's one of the things that we can do in the office that'll help you right away with BPPV. So always think about, you know, contacting your local physio if you're having these episodes. So one of the other things that we do, this fancy word here, habituating, is a fancy term for, some people just have chronic BPPV, and it comes on, you know, once a year or every couple of years. And what we try to do is do exercises that help you habituate with some of the after effects of the imbalance and the dizziness. So that's another reason where, you know, physio comes into the equation. Being movement experts, we can look at somebody and try to determine a plan for them by using exercise or stretching, which is my next point down, is the neck stretches and manual therapy to help with, you know, tight neck muscles. You know, when you have an episode of vertigo, there's a tendency to be really, you know, blocked in your movement and very protective. So the idea that moving your neck quickly, it just doesn't happen. So I see a lot of people that once their symptoms have diminished, we can start with some neck stretches, and even that might be one of the first things we do is work on some neck stretches and some manual therapy to help them with some of their neck symptoms. Mike, do we have any questions, or can we?
We've got a few here, but I think we can save these to the end and get to them. So.
Okay, fair enough. Okay, we'll carry on here. So the EPLEY maneuver, you know, fairly easy to do in the office, but it has to be done right. This is one of the things, if I just gave this slide to you and said, hey, go home and do the EPLEY maneuver, you kind of look at it and go, what am I supposed to do? Like, what are those angles? And it is velocity dependent. So, you know, when the clinician does this for you, with you, it's a feeling of being on a roller coaster, but it does make you feel better. It is the one therapy that we always tell people, it's going to hurt before it makes you, or it's going to make you feel awful before it makes you feel better. So this is the one thing that we can do in the office as clinicians that will help you with your BPPV. Another one, the BRANDT-DAROFF maneuver. This is one that you can do at home once you're in. You've been treated. We get people to do this maneuver at home that helps them with habituating to positional changes. These are done daily, and we can go into this with a little bit more detail later on if you'd like, but this is after a specific diagnosis of BPPV. So this is not necessarily something that I would recommend you practice at home without seeing somebody first to check your spine and hips and all those other things so that you don't get hurt. But this is I just wanted to share this slide with you, that these are really simple exercises that you don't need equipment for, but just should be willing to, you know, undertake the fact that it's going to make you feel worse before it makes you feel better. Okay, let's talk about Meniere's disease. And this is very different than BPPV. You will get vertigo symptoms. You will get, but most people present with ear fullness and hearing loss. That's the difference, is that with BPPV, you won't get hearing loss, but with Meniere's disease, you will get hearing loss. Now, there's an increased pressure of endolymph, and that's a fancy term. We'll go into a graphic next. We'll talk a little bit about the anatomy, and it'll make it a little bit more sense. It's where there's a lot of pressure built up. That endolymph is that fluid that moves those stalks of wheat back and forth, and it's just a buildup of pressure. So you can appreciate if there's more pressure, there's not going to be as much movement, and it's gonna basically affect your ability to have to hear and to also have imbalance.
Giacomo?
Yes.
What does someone asked what ear fullness means?
Yeah. So it literally feels like there's fluid in your ear. And so that endolymph is fluid. And so that's what that fullness, people come in and they'll say that I think I might have an ear infection. I have this fullness in my ear, and often they go to their GP and the GP prescribes them, antibiotics, and it's something that, may help if they have an ear infection. That can also be that feeling of ear fullness, but that's one of the things that distinguishes Meniere's disease from some of these other conditions, is that increase of pressure of the endolymph. So
okay, thanks.
Yeah, no problem. If there's any other questions, please feel free. Now, there's also people can get these drop attacks, and they're spontaneous in so much as feeling a bit, you just lose your legs from underneath you, and that's again another symptom that can happen with BPPV, but often more with Meniere's disease, and it only affects one ear. So that's the other part of it, is if we can look at it and say, well, it's one ear, that feeling of fullness, and there's hearing loss. We're not making the diagnosis as physiotherapists, but your ENT might diagnose you with Meniere's disease after various different tests that they can do to help to determine what is causing that. So here's the graphic I wanted to show you. Remember those nerves? We had the vestibular portion and the cochlear portion. So there's that how we hear. So that buildup of fluid causing the pressure into the entire system is being distorted, is causing the distortion to happen. So you're going to get that sound distortion, and you're going to get distortion of balance based on the fact that there's too much pressure in there. And so both of these are now carrying distorted signals back to the brain. So you can appreciate that this is a pretty difficult thing to live with when you have loss of hearing and an imbalance dysfunction. Okay.
Giacomo, can this fluid be drained?
Yes. Well, part of it, it's generally there's a sense to look at, managing the pressure with diuretics, low sodium diet. So there are lifestyle things you can do to help this. Generally, surgery is the last option, where they actually relieve pressure or to cut the vestibular portion that is causing that imbalance, and that would be pretty end stage to get to the point of surgery. But it's something transient. It can peak and valley, and so individuals with this don't always present like this. It is a chronic condition. It sometimes gets better with some therapy and some different medications. So again, these medications are there to help manage the symptoms, not necessarily the cause. But with diuretics and low sodium diets, keeping your pressures low, that has been shown to help. And then again, back to physiotherapy, because it's chronic. That's where, as physiotherapists, we can help the individual manage with those balance deficits when they do occur. So that's one of the things that we try to instill in people, is that when somebody comes in and they know they have Meniere's disease and they're having an attack, it's not a whole lot we can do. But once things settle down, they will be left with, there's something in physio we talk about, is the nervous system remembers. And so the actual lesion may have gone away, but your brain is remembering that pattern. And so we have to get out of that pattern and to try to manage it, not be slave to it. So that's where physiotherapy actually comes in and helps to retrain the balance system. Okay. Just had somebody last week with this. So vestibular neuritis, and it's the inflammation of the vestibular nerve. We'll go to another graphic, and it's a sudden onset due to a viral infection, like Lyme disease or shingles, and so it lasts, maybe about a week or so, and then it's gone. It's similar presentation to BPPV, so you can get that sense of vertigo. And yes, symptoms are exacerbated with head movements. And so the key here is that it's a viral infection that causes it. So, you may have had, these are just two examples. I'm not being an infectious disease specialist. There's probably more than these two examples, but these ones are what can cause the neuritis to happen. Okay. And so there we are. There's inflammation of the balance nerve, that portion there. We keep going. You guys are going to be experts on inner ear anatomy. So once again, we have that. There's your tympanic membrane, the outer ear, middle ear, and then the inner ear. And there's the inflammation of that nerve that's carrying signals back to the balance center of the brain to tell us where we are in space and time. And so when that gets inflamed, those signals can get distorted. And so, you know, treatments for the neuritis are different types of medications to help with to treat the actual vertiginous symptoms. Remember, again, vertigo is symptom, not the diagnosis. And often prednisone is a powerful anti-inflammatory that's used to help shrink that inflammation down so that symptoms can start to go away. Circ is an anti-nauseant many of you have taken for the vertiginous symptoms. So it's used in the different types of conditions that have vertigo as part of the symptomology. Antiviral medications are also used if that's something that is, you know, diagnosed as being neuritis. They can use antiviral medications. And then physio, once the symptoms have resolved, to once again retrain the balance system. So when an episode is happening, it's best to just wait for the inflammation to calm down and then seek help from a physiotherapist to get you on an exercise program to help with the balance. And we'll get into some of those exercises shortly. Okay. So I just want to talk about lightheadedness, because again, this often gets confused with dizziness or vertigo and orthostatic hypotension. That's the fancy term for it. You get up quickly and you feel lightheaded, the heavy legs feeling, low blood pressure that effectively causes that to happen. And most of us have had this. I wanted to address it because it is a cause of dizziness. So if you have low blood pressure or don't know you have low blood pressure, you may want to get that checked out. There might also be some dietary issues going on there that may cause you to have this, because it does kind of present like BPPV because it's somewhat positional. Sometimes it's hard to put two and two together. We get up really quickly and we get that feeling of lightheadedness and may think it's a vertigo or positional vertigo, but it may just be lightheadedness and a little more easily addressed than some of the other stuff. Okay. Wanted to talk very briefly about these things because they're on the scale of you know, less frequent and rare. Acoustic neuromas, that's a tumor on that nerve going back from the vestibular cochlear nerve there. So that is diagnosed usually with you know, an MRI. They can determine that, and that can be removed surgically. Vestibular migraines. Reading about vestibular migraines in the past, you know, there's some question as to whether or not that actually exists, or some train of thought that, you know, because it's up in the central nervous system, that it's not actually a vestibular. It's more the you know, in the brain, but the vestibular portion comes from the fact that you get vertigo episodes with these migraines. Fistulae, those are fancy terms for where that there's fluid-filled sacs that communicate between areas that shouldn't. And so that's something that can cause dizziness as well. Sometimes they fix those surgically. And then of course we have motion sickness that we talked about, that feeling that you're getting off a boat, that disembarkment syndrome, or being in a car, that can also cause dizziness. So like I said at the beginning, there's about 80 different causes of dizziness, and I don't want to go through all of them, but these are the ones that actually you know, probably have some serious effects here if you have this. Okay, so Mike, did we have any questions? I just want to address anything based on the presentation earlier on. If
yeah. So just a couple things here. Is there any diet or lifestyle changes that you can use to help with BPPV? That came from Catherine. Okay. Is there anything for that?
Yeah, Catherine, and anybody else who may have that question, I'm a firm believer that, you know, if you have BPPV, certainly get it addressed. We can address it in the office. We can if you have an active episode, and if you don't, if you're feeling that sense of wooziness and you know, that sense of fatigue, something as simple as just going out for a walk. Believe it or not, that stimulus of moving your head around, that up and down motion, those perturbations when you're walking, can actually be beneficial for that. It's not complicated, and there's a sense of fear, and you know, people are, I recommend using walking sticks, the poles, or going with a partner to walk, because let's face it, if you're going to have an episode, you don't want to be, you know, 20 minutes into your walk and have an episode. And I get it. There's definitely an anxiety around that, but short walks are probably the simplest thing you can do. And then, you know, of course, I would say if you want to get into something a bit more complex, then we could get you on a program, and I'll show you some exercises that you can be doing. But as far as dietary or anything else, lifestyle wise, I'm not entirely sure. That the research out there, you know, there's some research out there that says, you know, to not drink caffeine or to, you know, limit the alcohol. And I don't know if that's something that just is separate from BPPV, but that's something as simple as going out for a walk with a partner or with a gait aid would help you out tremendously. Is there anything else, Mike?
There's a few others, but we can get to those as we go.
Okay.
I just have one quick one, Giacomo, that pertains to stuff you just covered. Can prednisone be used for Meniere's as well?
Yeah, that's something, you know, not being an expert in that field as far as medication. I have had patients who are on prednisone for Meniere's, and you know, sometimes it's a medication that's given. It's a powerful anti-inflammatory, so it's one of those things. When we hear prednisone, it can go in and use it for anything from, you know, lupus and you know, other types of rheumatic conditions, all the way to, you know, having inner ear issues. So sometimes it is prescribed in low doses in hopes that the inflammation from, you know, that pressure is relieved. But you know, I think sometimes it's also prescribed as just a kind of a catch-all in case it is something else in lower doses. All right, we okay to move on, or?
Carry on, Giacomo.
Okay.
Go ahead.
Okay. So this is one of the things I like to qualify, is that, you know, vestibular exercises will often make you worse before you get better. And there's probably a bunch of people out there right now kind of sharing a little smile saying, yeah, that's for sure. Now, I would always recommend, you know, talk to a professional, whether it's myself or one of the other therapists in the office, or your doctor, or an ENT, an ear, nose, and throat doctor, who has a little bit of, you know, obviously they're at the top of the game with this stuff, but talk to somebody before you start an exercise program that puts you in peril of losing your balance. Because, you know, we see people coming in with head injuries and other orthopedic injuries from falling. So I want to make sure you mitigate that. So this is a nice little graphic where things that you can be doing right now at home, and very simple. And it's just some neck movements, some stretches to move yourself out of the horizontal plane and into more of that vertical plane and into rotational directions. The eye exercises, we get people to do those in bed, and there's a little bit more to them, where as physios, we give people exercises that help them with eye movements and some of the actual ability. Remember, we talked about the eyes, the ears, and that sense of proprioception all work together. So this is where we use the eyes. And in the case of the neck stretches, we're actually moving again, the ears are moving with that, and then we're moving in different directions. So picking up objects off the floor, I get people to do that from a seated position. All these exercises are done seated, by the way, or supine. We start with these exercises first, and make sure that, again, you're not standing and doing these, losing your balance and potentially having a fall. And so, you know, doing something as simple as stretching your shoulders, relaxing some of the neck musculature will aid in some of the recovery. But the key to these exercises is the head movement in different directions. Once the symptoms have diminished, then we get people moving in these different directions to help with their with some of the symptomology. Okay. These are other exercises you can do right away. Now, these are a little more advanced. Again, remember, movement is very complex. Looks pretty simple. We do this all the time, though. I mean, if anybody goes out golfing or they pick up a bag of groceries, maybe we don't kick our leg back as far, but sometimes we have to lift our leg and lean forward, and it's, you know, picking something up. We call that a drinking bird, or some other name for it. But the point is that these are functional exercises, moving away from our center of mass. You can see here, you know, this woman has her hands on her hips, which would be roughly where her center of mass is, her center of gravity, and she's moving away from it. So again, that translational movement and challenging the vestibular system in certain directions, and she's moving her head towards the movement here. It's kind of on a little bit of an arc, and so that challenges the vestibular system as well. This one is very challenging for anybody who's had any type of vertigo or balance dysfunction. This one is a very challenging exercises, but if you're not experiencing that right now, there's no reason why you can't try that. And some of you may be asking, well, how many times a day do I do this, and how many, you know, what's the repetition that I do? And I would say that that's something that's very it's variable. It depends on your level of exercise ability, age. Have you done exercise like this before? I wouldn't recommend somebody who is, you know, relatively sedentary to go out and start doing these. They look very simple, but believe me, all it takes is a little stutter and down you go. And so things that you should be advised by a physiotherapist to do. But if you're feeling good and you're you know, confident, then these are some of the exercises you should be doing at home right now. Another little graphic here, again, moving outside of your center of mass. Simple exercise, moving your hands over your head. Again, very, very simple, but then you get into something a little more difficult where you're actually bringing your knee towards your chest. And we do this test in physiotherapy where we look at people's movement of their back and whatnot. And it's quite challenging to actually get somebody to pull their knee towards their chest and maintain that position. Same with this one here where you're flaring out. Again, this is a very complicated movement, folks. So I wouldn't go out and try this one right away. I'd be happy to chat with you about these exercises at some point. But once again, they're kind of out of a yoga textbook as well. So if you're feeling confident to do some of these exercises, you can certainly try them and make sure that you have an area where you can hold on before you actually go do these without any support. How are we doing here so far, guys?
Giacomo, on the last slide, the C movement, was that moving the leg towards that? Yeah, was that towards the back?
Yeah, so it's kind of like this swooping motion. Yeah, it's a bit of a swooping, arcing motion. This one, as compared to this one here in B, it's side to side. And again, you can see her leaning a little bit to the side. So it's kind of like making a semicircle, and she's looking towards the movement there.
Great.
Yeah. Okay, so thanks everyone. I kind of ended a little bit abruptly there, but there's a ton of exercises that we can do, and those are a snapshot of things that you can start doing at home. They're fairly safe. You can advance from, you know, something relatively easy, a little bit harder, into something more difficult. Same with these exercises here. The progression from A to B to C is a little more difficult. This one here is fairly challenging, I'll admit it. I mean, I show this to people all the time, and it's very difficult. So,
Giacomo, you had a bit of an offer tonight, right? Because I know some people probably may not stick around for the question period, and I'm sure you could probably refer back to some things after.
Okay, so we'll let's
get to that so people know what's available to them.
Yeah, so if anybody wants to contact me at any point, I'll put this graphic up afterwards, and this will be available to everybody for reviewing, and we'll get to some of the questions. But yeah, let's move along here. So just keep calm, everybody. Just try to relax. Message me. You're gonna have my information. If we've had a lot of good questions this week leading up to the presentation. Mike has been fielding a lot of questions, and myself, and we're trying to answer as many as we can. These things can get very complicated, and sometimes we can go, oh, gosh, people have seen 4 and 5 doctors before they actually get a diagnosis. So, you know, we're not trying to make any diagnoses here tonight. We're just trying to educate everybody on what we can do to help you once you have a diagnosis. You know, these things get very complicated, and how ENTs will actually, and neurologists will diagnose these things. So I want everybody just to try to digest all this stuff. There's a lot of information, and I'm happy to help you with interpreting that information. And so we're going to go into some questions. So think about some questions. I know there's a bunch there.
Yeah, they're coming up.
Yeah, And I just wanted to, I know we're coming up for time
Get
here.
to you. Why don't we do the offer and then we can, just so people who want,
Okay, yeah, so
they know what's available.
Yeah, we can offer everybody here, tonight, or if you'd like, a virtual consult or a 15-minute phone consult. I'm happy to chat with anybody, and I mean that from the bottom of my heart. It's not a sales pitch or anything. This is something we want to make sure that you walk away with saying, well, I might have a couple questions, and I'd really like to chat with you before I actually get get into the office. And I think I've answered about a dozen emails this week, and that's a testament to, we really truly believe in this, because a lot of people are walking out there with with balance disorders, and they don't know where to go. And that poll at the beginning where Mike put that out there, and people out there saying, well, I've never had any treatment for it. There are treatments available depending on what you have, and if it's a balance issue, we can help you. And if it is chronic, then we can still help you with it. I mean, exercise is one of those equalizing treatments where it's really unfortunate that we actually have to do them. You can't just swallow a pill and get it done. You have to do them, but under supervision, it always helps. So, like I said, very happy to offer this. Go ahead, Mike.
In the chat, folks, if you wanted to maybe take advantage of a complimentary 15 minutes with Giacomo to do a virtual consult face-to-face like this, or a phone consult, just type into the chat. Let us know if you want virtual or phone, and Giacomo will reach out to you. There's no obligations. If you have questions that maybe don't all get answered tonight, he's happy to talk to you. So feel free to type in virtual if you want the virtual consult, or phone consult, and type that into the chat, and then we can kind of touch base with you and connect, and Giacomo can reach out to you and see what's going on. Okay. So feel free to put that in there if you want, and then like I said, we'll keep track and pass along your name to Giacomo, and he'll be in touch with you to set that up.
Yeah, I'm like I said, I'm very happy to chat with you. Either way, if you want to see my mug, or if you want to just hear my voice, that's fine. I'm happy to chat. We could set something up, no problem. So, were there any questions that we can answer?
Yeah. So we've got a bunch of them. I think Aaron has a few, and I have a few. So
okay.
Most importantly, there was someone earlier on, Edward, who he said the issue with BPPV and doing nothing about it was you can't get treatment in a timely manner, and that is true in this scenario, for sure, Edward. And this is what Giacomo is why he wanted to do this talk tonight, to let you know that there are physios like ourselves that do treat this, and you can always reach out, call the office, email him right away, and he's here to help you. So I think that's important to know.
It really is, and that's the thing. A lot of our physios are trained in it, and I definitely have a preference in treating these types of things. But it's not something. You're right, Edward. You can wait things out. You can wait out a chest infection and it'll get better. But if you get the therapy for it, it certainly gets you back and moving a lot easier. So I'm quite happy to chat about it, and maybe we can touch base. And if you're near one of the clinics when you're having an episode, I'd be happy to help you out.
Okay, Aaron, do you want to give Giacomo a couple of the questions that came in there?
Yeah, sure. So I think a common theme that came up was people wondering about things you can do to prevent vertigo, or things that may be causing vertigo. I know you talked a lot about the different exercises, but some other things people were wondering about were quantity or quality of sleep, weight, or even muscular tightness, and if those things would have an effect on dizziness or potentially vertigo.
Yeah. So there we didn't get into something we see a lot of is cervicogenic dizziness, and is that a standalone diagnosis? Some people who've had whiplash or a concussion can have that, and so there's a tendency. I've treated a number of patients who come in and they don't have BPPV, they don't have anything else, but history tells us that they had a concussion a couple of years ago, or you know, was a contact athlete. You know, we work in King Township, and so we see a lot of equestrian folks who've been, you know, whipped back by a horse, and turns out that, you know, there are anatomically portions in the neck and parts of the nerves that can relay signals of balance to the brain. So we see this all the time after concussions and concussive episodes where, yes, so tight neck muscles, in a simple answer, can cause the dizziness. Aaron, there was something else you had mentioned about lifestyle or predictability for episodes.
Yep, so the other two were sleep and weight.
Yeah, so I'm not sure about weight. You know, that doesn't necessarily, as far as the vestibular mechanism is concerned, but if, you know, something to that effect, like when we talk about Meniere's disease, certainly, you know, that's again, it's not much to do with the weight. It's more to do with the pressure of the endolymph. So dietary changes can help that. And then as far as sleep, you know, that can cause that sense of lightheadedness or drowsiness, that sort of thing. So that's why they say not so much in the way of caffeine or alcohol, because that can, you know, keep you up at night if you're, you know, your antidiuretic hormone is switched off and you're having to pee all night. You're going to be up and not getting rest. And conversely, with caffeine, you're also not getting rest as well. So if you're an anxious person and you're not getting a lot of rest, you could certainly feel the effects of that. Not to mention, you know, in diabetics, if you're pre-diabetic or don't know that you may be feeling that sense of dizziness, and it may be actually, you know, from potential of diabetes.
Giacomo, there was a question earlier. How long would post-concussion dizziness last, and how do you get rid of it? I'm assuming this is, like you said, it's just retraining exercises.
It is. I mean, you know, post-concussion stuff. I mean, being in the sports world, we followed guys like Sidney Crosby, and it was like, you know, 3 years, and, you know, he finally got some treatment that was more neck related, and then, you know, off he went. So, you know, it can last a long time. And so post-concussion syndrome, there's many things that can happen, you know, whether it's chronic headaches or chronic neck pain, arthritis from having multiple concussions and having arthritis that lead to headaches from the neck, cervicogenic neck pain or headaches. So it can last a long time unless it's treated. And that's the key with this, is that generally those little autoconia will dissolve on their own spontaneously, and people go through these episodes where they're off for 2 weeks and then they wake up one morning and they're fine. But from a post-concussion perspective, it generally needs a little bit more TLC and sort of that ability to work through some of those balance impairments. So it's a little bit more complicated. So it can last a long time, and it can take a long time to actually recover from it. But it's like anything. We always say it's like brushing your teeth. We do it every day, twice a day, 3 times a day, if we've eaten like a Greek salad or something. But, you know, there's no reason why we can't exercise 3 times a day and do some of these vestibular exercises. There's really no reason why. I can't employ that enough.
Great. Another question earlier on, someone mentioned they were on Circ when they're having a vertigo episode. Other than manipulation like the EPLEYs, is there anything else that people can do to prevent vertigo?
Yeah, again, it's depending on what it is. So the EPLEY is really specific to you know, BPPV, and if you're having vertigo secondary to some other issue, then it's a matter of depending on what's causing that. So if we go back to the Meniere's disease, it could be you know, something where we are that dietary change or taking medication to decrease the swelling around the nerve. So depending on what's causing the vertigo, yes, you can do certain things to help it if you know that you've been diagnosed with something. But with BPPV, generally not. I mean, I wouldn't necessarily recommend you go on a you know, to Canada's Wonderland or something like that, or participate in activities that could involve you know, sudden movements of the head or abrupt stops of the head. That would be something that I would definitely avoid. water skiing, classic example, you know, your head gets whipped back, that sort of thing I would definitely avoid.
Okay. There was a question that just came in now. Have you heard of the Foster maneuver?
I saw that. Not familiar with it. There's a few other maneuvers that we do. You know, that BRANDT-DAROFF. Then there's the Samant, a modified Samant. There's the EPLEY maneuver. Not terribly familiar with the Foster maneuver, so I apologize. I'd have to look into that. So that's not one that I use in clinic.
Okay.
Okay, so somebody, Janet, say it works. Yeah. So we'll yeah.
Aaron, any others there?
Yeah, I have a couple. I think this one will be quick. Just wondering if headaches are commonly occur with vertigo or dizziness symptoms. But again, I think, correct me if I'm wrong, Giacomo, but it most likely just comes down to the source of the vertigo, what's causing it, and then that could potentially be associated with headaches.
Yeah, exactly. And then we talked about that vestibular migraine that can actually, you know, can occur. So that's where the jury's out on that one, Aaron, and whoever asked that question. So, you know, the headache part of it is not necessarily, you know, a symptom of, or it is a symptom, but not necessarily the cause.
Right. I have another one here just about like natural substance. Danielle is wondering if you've heard of, I might mispronounce this, but ginkgo biloba.
Ginkgo biloba, yeah. Yeah, I'm not familiar. I mean, a lot of my patients come in taking as an anti-nauseant. They take you know, ginger. I'm not up to speed on all the naturopathic stuff. We have a naturopath in the office in Nobleton, Dr. Mallory Reinthaler, if anybody is interested in chatting with her about it. But from an anti-nausea perspective, yeah, the ginger is one of those things. Like Gravel makes a ginger-based, you know, non-medicinal naturopathic version. So I apologize. It's not my forte and my scope, but there are some things you can take. Again, you're looking at a low sodium diet, that sort of thing for certain conditions. Caffeine, minimizing the amount of caffeine and the like. So that's something that maybe, I'm sorry, I can't answer that in full, but maybe, are there any other questions?
I didn't have anything else here. There was talk of a Colorado vertigo treatment. Have you heard of that, Giacomo?
There's so many out there.
So many,
yeah, and I tend to really stick to some of my more tried, tested, and true ones. So there's
looks like Janet just said that's the Foster one.
Yeah. So okay. Thanks, Janet. Yeah, there's the Cawthorn Cooksey exercises, and those are there's a slew of them out there. And really, it's just knowing what it is that you have, and that's where those exercises and those different maneuvers will actually help hone in on the actual therapy for the condition.
Just one other final questions coming in here. A couple of things here. One, can sudden changes in weather or pressure cause dizziness? Giacomo, do you know about that?
You know what? It's a common question, and looking at some of the research around the country, you know, the people experience these types of things in fairly flat, stable climates, like, you know, Arizona or in the Southwest, where it's fairly stable. There's really no spike in condition, whether you live, you know, in low pressure areas, high pressure areas. That can cause dizziness. You know, if you go from a high pressure system, you know, up in the mountains, like here in Vancouver, you're at sea level, then you go all the way up to Whistler. People can get that sort of altitude sickness, but it doesn't necessarily affect it. So across the country in different geographical locales, there's the incidence and prevalence are about the same.
Okay.
Yeah.
Couple last quick things here. And is there a connection between women's hormones and being like off balance? Is there anything that you found there, or does age have any influence on vertigo?
I can certainly answer the age question. Yes, it does. Unfortunately, incidence and prevalence goes up with age. Women are the bearers of more vertiginous episodes than men. So whether that's in their 40s, it does happen later in life, that is for sure. if it's hormonally related. Again, a little bit out of my scope, but maybe putting 2 and 2 together, that if you're a female and a little bit older, it's going to happen with a little more frequency. That's for sure. The research does support that as far as that's concerned, Mike.
Okay, thank you.
Yeah.
Can you just put up the one screen there for the next webinar? We're just going to be wrapping up here, folks.
Yeah.
And before we let you go, first of all, thanks, Giacomo. A wonderful session. Plenty of information, which has been super helpful. This is a really, this is a really debilitating condition, and I think the big message to take away tonight is there is an option for people. But coming up, guys, we've got a couple more webinars for the end of 2020 here in a month. Wednesday, November 11th, there's going to be a talk from our pelvic health therapist, Nadine Gowie, here at Nobleton Physio on women's pelvic health. So she's going to discuss what pelvic physio is, common conditions treated, when should you seek a pelvic physio, it may be for during pregnancy or postpartum. Can menopause cause changes to your pelvic health? She's going to have a lot of information, maybe dispel some myths and answer a bunch of questions. So there'll be a sign up coming out in a couple weeks, a few weeks for that. So stay tuned, and you know, I think she'd love to get a big crowd like we had tonight.
I agree, Mike. I think this is I would encourage any of the men in the audience, if anybody, you know, you can listen to this, it's fine. I think if you have a partner who's experienced some of this stuff, it's really informative. And Nadine has helped educate us in the clinic on, you know, certain questions to ask, and making sure that, you know, even as your partner helping you out with getting through some of these things. So some of the men in the audience, feel free to join in and listen. You know, obviously it's meant mostly for the ladies in the audience, but I think it's important for men to understand what women go through, and to help to alleviate some of the misconceptions and all that around pelvic health. So thanks to Nadine for that in advance. I want to thank everybody sincerely from the bottom of my heart. I love doing these things, Mike. I really sincerely enjoy it. I think what we do as physiotherapists is, you know, probably 80% education and just helping people understand what's going on in their lives and to help them get better. So thank you from the bottom of my heart. Aaron, thank you so much for helping us out here once again. Yeah, it's a team effort as always between us, and I hope to see you in the new year. I don't think I'm doing any more of these this year, but I really look forward to seeing you guys in the new year, and thank you very much.
Great, thanks guys. Everybody, thank you for attending tonight. And again, if you wanted to speak to Giacomo, feel free to email him. You can also take him up on the offer of a free phone consult or virtual. Just let us know, and he'll be happy to help you out and maybe offer you some new exercises or tips you might need to get through this problem. Other than that, everyone, thanks once again. Enjoy the rest of your evening. Happy Thanksgiving to everyone, and we'll see you all very soon. Thanks very much.
Thanks, everyone.